Hello, everyone, and welcome to this FRCR 2B exam mastery. Okay, we are going to discuss in the next 1 hour plus various tactics and techniques that you can use to pass your exam. And this is going to be a very comprehensive talk. So you have to bear with me. It's quite long, and it has been presented recently during the rapid reporting course. So if you're on that course, then I'm afraid this is a little bit of a repetition, but we will cover most of the essential bits about the FRCR 2B exam, and we're going to delve in detail a little bit. Okay. So first of all, I need you all to consider, please, can you get that on your phone, open the camera, and open this slido.com, because we're going to make this as interactive as possible. Okay. So if you can just get that Slido, and if you can just say yes when if you're ready. Okay, just put yes in the chat box when you're ready, or on Slido. My name is Koshi Jacob. I'm a consultant radiologist. I've been a radiologist now for close to a consultant for more than 15 years, and I was a registrar before that. So I've done almost 20 years of radiology now, and I've been involved in education. I did medicine before that, MRCP, and I'm also a trained coach. I've got a qualification in coaching, and I think more interestingly for you, I've been involved with developing revised radiology. Just a little bit before we start about revised radiology itself, okay? I think, you might find it useful or not, but our mission, okay, if there's a mission statement we have, that's to give you everything you need to pass your radiology exams, particularly your FRCR 2B exams, on the first sitting. And we consider ourselves the kind of leading global platform, and as a result of that, we have got prizes as the best educational software in both generally and in radiology in the southwest of England. Our purpose is to help you pass first time, and our vision and our values and what's important to us is helping people. We like, I have a big value around being productive, around giving. Everything that all our profits are given to great causes, and those great causes are given on our website. If you go to the About Us section, we support 3 charities, and all our profits, 100% of it, goes to support those 3 charities. One is Accelerate UK, which is a UK-based charity. Then there's a charity called Pallium India, which is a palliative care charity, which strives to sort of alleviate health-related suffering, particularly in the state of Kerala, and something that I've got a personal connection with. And the third one is from my alumnus, the Friends of Vellore UK. The Christian Medical College of Vellore is where I trained, and the Friends of Vellore are trying to support that program that helps poor people get, or people who can't afford free healthcare, get free healthcare in Tamil Nadu, India. So that's just a little bit about revised radiology. I thought that may be interesting for you. And today's webinar, what we're going to deal with is we're going to look at the stage of preparation. We're going to look at how you can score an 8, and we've had a few. We've just had some fantastic results, and we've had at least a couple of people who came back and said, I scored an 8. So we're going to show you how to do that. We're going to look at what revised radiology can do, but I'm going to put that right at the end, actually. And we're then going to look at the long cases and the vivas and how to deal with them in confidence. You've got exactly about 3 months left, so this is a very good time to be looking at this. Now, the session is being recorded, and there will be time for questions at the end, but let me just get you to see if your Slido is working well if you are ready to get started on the Slido, just say yes. And then I know that we can be a little bit interactive here. Okay, if you can just open your Slido up and say yes, I know that. Excellent. I've got one there. Any more yeses? Then we know that we are, we've got some people attentive on this webinar. Excellent. Okay, I'm just going to take it for granted that you guys are, but please can you open up Slido, because one of the next question I have for you is, when are you sitting your FRCR exams? So again, it's anonymous, but when are you sitting? Is it September? Is it January? Is it March? Is it later than March? Just put that down on the thing. So September 29th, September 2023, September, one person doesn't know, which is fair enough. You don't know, and maybe perhaps you're even on this webinar having done your part one or not even started, and you want to know a little bit about part two. Well, I want to give you some kudos there for being so proactive. But the don't knows can also be because you don't know when you'll get a seat, and I don't know if that's the case. Yeah, if I get a slot in March, yeah, exactly. Those are some of the challenges that the FRCR exam faces. Okay, let's move on. Now, no matter how skilled or talented you are, without expert guidance, you will never reach your full potential. And that's a phrase that I love. It just, and I have always, right from the days when I was in being a registrar, I've believed in getting expert guidance, and I've gone to different people to get that. And also after finishing, I've had a mentor, I've had coaches, and I think having expert guidance and knowing what to do is really important. So let's first of all deal with the rapid reporting. So you have 35 cases to do in 30 minutes. So you have a bit over a minute each. You have, it's the kind of cases you get are the accident and emergency and GP pile cases. Now, I have to stress this because too many people prepare for the rapid reporting exam like they prepare for a spotter exam that in your own country you have. Now, the spotter's exam is not a rapid reporting exam. The rapid reporting exam is to see whether you can pick up fractures, whether you can pick up emergencies. It is not to check whether you can pick up, vague conditions like synovial optic rheumatosis. It's not about that. It is really about the kind of cases you get in your GP reporting pile or A&E pile. Now, if you haven't worked in the UK or you haven't done any X-ray plain film reporting, what I'm saying to you might sound a little it's unfamiliar because you probably haven't done much plain film reporting. But I have to say, you have to do plain film reporting to know what I'm speaking about. The other thing is there can only be one abnormality on an X-ray. Okay, so if you have two abnormalities, either it's you're overcalling one of them, or it's part of a condition like Colles fracture, where you have a fracture of the distal radius and an ulnar styloid fracture, then you call it a Colles fracture and you have two fractures. Or let's say a bimalleolar fracture or a trimalleolar fracture. Those kind of things, or a small bowel obstruction with pneumoperitoneum. It's the same thing, actually. It's because of the one is due to the other. So in those cases, you could have two diagnoses, but they're actually one. And approximately 40 to 60% of your cases are going to be normal or abnormal. So, and the path mark is approximately 27 out of 30. Now, sometimes it drops to 26 because there may be a film or two that are too difficult. And in a recent exam, the path mark for the whole exam was only 8%. The rapid reporting exam was only 8%. So some exams can be very hard, and then they'll drop the grade boundaries. So what that means is the RCR is willing to accept a 10% miss rate, which in real life would get you in front of the GMC. Now, my strategy, if I were you, in practicing for the rapids, would be to finish at least 2 or 3 packets a day. Make checklists as you prepare and repeat any 30 to 60 packets in the Revised Radiology platform. And the reason I say Revised Radiology is because we have used a particular algorithm to create packets that are very, very similar, if not almost identical to what you'll get in the exam. So if there is a diagnosis that you are seeing in somewhere, either in the exam, somewhere else that is not in the Revised Radiology packets, it's not a diagnosis for rapid reporting. And the only exception to that would be one diagnosis that we're still looking for, which is unilateral facet dislocation in the neck. Apart from that, we have every other diagnosis, and even that we have a case of facet dislocation, but it's just not unilateral. That can come up in the exam, but you can always look it up in Google or Radiopedia and get that. But apart from that, every single diagnosis that you get in the exam is covered. Okay. Develop a system for looking at each packet and develop a system at looking at each image. So I'm just going to show you very briefly what I'm going to just demonstrate this system. So I'm just going to get this to the field of view so that you can see it here. And I'm just going to show you how I believe you should try and look at this. So let's go to the 2B section. Let's go to the rapid reporting. Let's open a curated packet. And we'll open packet 1. That's easiest. I know it works. I'm just going to open that. And when I say a system for looking at each image, I'm talking about in a chest X-ray, for example, you start with, you have a system for looking at it, and that's what I'm talking about. Now, when you open your exam, and this is exactly the same platform as the college exam, the first thing I would do is open that box there so that you have all the questions in front of you. The next thing I would do is go through all the cases to see if there is an abnormality. As you can see here, there is an abnormality. I'm not going to answer it because this is actually one of the sets. The second one, open it. Is there an abnormality? If there is an abnormality, write abnormal and write the reason, write the diagnosis. Next one, is that normal? If it's normal, don't say anything. Don't write anything, okay? Just flag it or leave it. Because when you put a diagnosis, it will highlight. Okay, so if, for example, in this case, you say right middle zone collapse or whatever you put, the minute you put that and go, it gets highlighted. So you know the ones that you haven't answered. Okay, and then you go through the packets, and once you've picked up all the abnormals, I would say go back again now and start looking at the normals carefully to see if there's any obvious abnormality. Now, when I say obvious, I mean obvious. And that means, is it the kind of case that you would confidently put into a textbook of rapid reporting or textbook of radiology as a typical case of that diagnosis? So that's when I mean. So if it's subtle and very, very subtle and you're struggling to see it, it probably is normal. Okay, so that was just to demonstrate the rapids, the system I would use. Now, I would make notes as you go, and we've got a note section you can use, and there are checklists for rapid reporting, which I strongly recommend because there are only so many diagnoses that you can get in rapid reporting. Make a checklist, and when I sat the exam, even though it was almost 15 years ago, I actually used to look for those abnormalities. So if I had a skull X-ray, I would be looking to see, is there a lytic lesion? Is there a sclerotic lesion? Is there a fracture? Is there, and the type of fractures as well, I'd be looking for those fractures. And then if I found it, then I've found my diagnosis. I don't have to waste any more time. So if you have a checklist in your brain, that will help great, okay? And if you want to see more images, use Radiopedia. And if you have access to StatDX, that's brilliant, okay? Review your statistics. Make sure that you're getting consistently 28, 29, 30. And my goal would be to get 30 out of 30. Aim for 0 overcalls. This is one part of the exam that you can score an 8. You probably, there was one person this time who scored, one of our candidates who scored an 8 in Vivas, but it's incredibly rare. And that's the kind of person who might be getting the Frank Doyle Prize, okay? So the Vivas are hard to score, but the Rapids, you can score an 8. So my question then to you is, and you can answer that on the Slido, have you created a revision plan for the Rapids? And I just want a little bit of feedback. Have you created a revision plan for the Rapids? You can answer that question for me while I just have a sip of my coffee. Okay, you haven't got a revision plan for Rapids, okay? Anyone else? Okay, so you don't have a revision plan. Okay, well, here's a revision plan. Okay, not yet. Okay, here's a revision plan. I'll try and give it to you. So first of all, okay, so I've already done this. So spend 10 minutes looking for abnormal films, then go through the rest of the films to see if they're normal. Flag every not sure case. So there's a flagging system. I don't know if I showed you that. I probably didn't. Let me see if I can show you that. That's the flag. So if you're not sure, just put it on flag so that you can come back to it later. And if you count only 15 abnormals, look for 2 or 3 discriminator films among the normals. But if they're not there, then it probably is probably only 15. Spend the last 5 minutes looking for mistakes like misspelling of site marker, mislabeling, and that kind of stuff. And then if you're not sure about anything, mark it normal. So use this system every time you practice, because the secret of success in this exam is getting a daily routine. So in terms of a daily routine, I suggest if you've got 90 days left, do 2 to 3 packets every day for the next 40 days, and then do at least 1 or 2 packets after that. Repeat the same packets again. You don't need to do any other packets. And in fact, I would recommend that you don't do any other packets apart from the ones that are there, the 80 packets. So that you don't overcall. It's very important that you don't work with cases that are too hard. And the classification for getting the scoring system, this is not really important, but if you have a normal film and you correctly classify it as normal, you get a mark. If, for example, you pick up a normal variant or something that is there and you mention it, you'll get 0.5 marks. If it's an abnormal film and you correctly classify it and correctly identify and correctly put the side marker right or left, you get a mark, but anything else is wrong, okay? So simulation is the key, and that's the key for all 3 parts of the exam. Only practice and conditions that simulate the exam. So practice reporting 30 cases in 25 minutes. Each packet should have around 12 to 18 abnormals. And don't be worried about making mistakes, okay? Because mistakes are how you learn. And the 7 common mistakes, I think the number 1, and I asked you this question before, is not having a plan. I think that's the number 1 mistake. Not having enough revision resources, images to look at, not analyzing your weak areas with performance measurement statistics, not being aware of where you're overcalling. So if you're overcalling hilar abnormalities and you're not aware of that, that's a problem. The other thing I think is quite important is even people who do our packets sometimes do it very quickly and do it a little bit. They do a little bit of the packet and then they go for a coffee break and they come back and do the rest. That's not how you do the exam. All the practice, always do it as if it's an exam. The other one is using software simulating the exam is very useful. And I'll demonstrate why. Because when you click on that, you've got all these different menus. Now, if you knew that W will do a windowing, and you know that R will rotate the thing, or you know that Z will zoom, then you don't even have to click on that. You know the key, the key stroke. So if you press an E, then it resets the image. So that's also very helpful to know. And the reason I mentioned the last one is that if you choose a course where they give you very hard cases, you could end up an overcaller. So learning from mistakes, that's a really important thing. Do not think of failure either because you failed the last exam or not, or because you're not doing well in the beginning. It's just the beginning of success. Okay, you're just one step away from success. And you have done the right things by signing up, by showing up, by taking action. And you know, that's the kind of mindset that we need from people. Now, let's go on to the long cases. The long cases, I think what we're going to cover today really is the 4 mistakes to avoid, time management techniques, and how to get faster. Okay, I'm just going to use this phrase. Time isn't the main thing; it's the only thing, and this is particularly important when we're thinking of the long cases. In the scoring system for longs, a fail is where, so if you don't answer anything, you get a 3. If you made significant observations, you missed significant observations, you didn't make the correct diagnosis, you'll get a 4, which is a fail, a bad fail, if you like. A borderline fail is where you've mentioned 1 or 2 key diagnoses and you've missed some of the observations, which might explain why there are quite a few people who do get 5s in long cases. And that's because they think they've written a lot, but they haven't written what the examiner is looking for. But if you pick up most of the observations, you pick up the principal diagnosis, you mention the additional relevant details, principal diagnosis, you get a 6. And if you go further than that, you get a 7, and a perfect answer is an 8. With the longs, the important thing is to always do every case, okay? So don't leave any blanks. In the long cases, which I'll try and open up now. So let me just finish that. Let's go back to, let's finish that case. What I'll do is I'll go back to Farsia 2B and let's go to long cases. And I'll just get the long case packets opened. I'll just open packet 1. Okay, so while I'm speaking, I'll get that opened so we can see how to approach it. The first thing is not mentioning relevant negative findings. So, for example, if you have a small bowel obstruction, you should really mention there's no free fluid and there's no free air. Okay, so those are relevant to the case. So that comes through practice and through knowing what the clinician is looking for. Okay. If you give differentials, please list them in the order of likelihood. And all these mistakes we've taken this from the Royal College website and the examiner reports. And this is what they're saying. And we're telling you all of it in a webinar now. And giving a lot of differentials will show that you are not very sure. So limiting it to about 2 or 3 is a good idea. And the other thing is not including appropriate investigation. So you need to fill all the bits. Okay. So I'm going to show you how that looks. Did I start it? Maybe I didn't. Okay, I'm just going to start the packet now. Yeah, let it start, and then hopefully it will open up in a minute. Now, in terms of management techniques, time management techniques to go through the long cases, I'm going to demonstrate this in a second. My recommendation is that you go through the easy cases first, finish these as quickly as possible. If there are cross-sectional studies, look at the cross-section first, and then look at the plain film. And then look through all the modalities to look for clues in the diagnosis. So if I just show you that now here. So here, for example, the first thing I would do is open that out. So you have, and make sure that you fill all these things. So I have a little technique, which is putting dashes and basically copying that dash to all the sections, all the questions straight away. So, and you can do that for all the cases. And the other thing is I would look through all the cases right at the beginning to see which cases have the fewer modalities. Which do you think you will finish quickly? start with those. So a bone scan with just one, you can probably finish that quickly. You can probably finish question 4 quickly, and then maybe do question 5, and then go back to, go back to question 1 maybe, and then question 2 and question 3 in that order. So look at the packets and decide, and you can flag anything that you feel you need to write more in, but it's important to write in every box and management as well. But getting faster in longs has to do with typing speed. So you've got to aim for 10 minutes per case, spending only 7 to 8 minutes on the easy cases, and maybe slightly longer. What will slow you down is if, for example, you are searching for all these boxes, okay? So let's say you're opening this, you want a window. If you know window is W, then you can do that. If R is rotate, you can rotate. If it's zoom, you can zoom, you can pan. And then the most important button is the E button, which is the reset. And then, you can scroll. And you can also use your keyboard up, down, sideways button to scroll through the cases, okay? Right. Don't use long sentences, use bullet points. And here's a template I already showed you where you could write, for example, further investigations, referral to, and then copy and paste that into all the boxes just to save time, because time is going to be your biggest enemy. So that really is a kind of really quick dive through the longs. And what I'd recommend, if I've been speaking too fast, which I probably have because we've got a lot to cover, is to go back and watch this recording, slow it down, and get a plan together. In terms of a plan, I would recommend you do at least 1 packet of longs every day, on every weekday or weekend, about 5 packets per week. And we've got 30 packets in our written packets. And if you're doing any of our courses, you'll get packets for those as well. But if you do 1 a week, those 5 a week, that should be more than enough to get you through the long cases, okay? And you'll find that most of the long cases that you get in the exam will be reflected in the revised radiology packets, which is probably very comforting. So let's go into the last bit, the vivas. What are we going to do about the vivas? So here, I think the important word is script. Having a script and presenting yourself as a safe radiologist, and I'll just go through some mistakes to avoid. First of all, we've got to believe in our ability to pass. Okay, if you don't believe in your ability to pass, then you're set up to fail. So get the right attitude, get the right technique, polish your skills with reporting, and see for yourself whether you're behaving like a successful Viva candidate. Because a good system shortens the road to the goal. So here's a script you could start. So this is and describe the image. And I would use a systematic approach to every body part. So learn how you're going to describe the chest, how you're going to describe the abdomen, how you're going to describe a pelvic, how you're going to describe a shoulder. Have a script for how you're going to look at these different parts of the body. There aren't that many. There are probably around 20 different views that they can give you for x-rays. And for CT, again, if it's a CT abdomen, CT chest, have a checklist. So this is and then state your observations. There is so this is a x-ray or CT, and then there is mention all your positive findings, and then interpret it like you do in the long cases. Okay, so this is a sort of well-defined lesion in the head of the fibula. It's got narrow zone of transition. And if you're sure about it, just say there's an enchondroma, and then that's the end of the film. But if you're not sure about it, it's a good idea to describe it and then say the interpretation, this looks benign, and there is no, bony destruction to suggest malignancy, or a sinister pathology like infection or neoplasm. So that's where you say, you use the negative finding and then interpret it. And then if you want to be sure and you want to buy some time, say, I'm looking at my review areas, which are, and always verbalize your thought process. It helps the examiner. And if you've developed your thought process, then you can verbalize it and it will look slick. And then give your diagnosis. The most likely diagnosis for this is this, because of the clinical findings and because the clinical information that I've been given. But the differentials would also include this, but these are less likely because, and then reinforce why you think the main diagnosis is correct. And then you can ask for further tests. The management of this patient would include getting a CT scan and to confirm the diagnosis. And if negative, we can do this or whatever. And then I would recommend referring to whoever with a view to getting this done. So knowing how the patient is managed is really helpful is really helpful for the examiner to know that you're a good clinical radiologist. And then if it's a long case, if it's a really long Viva case, I would summarize. And the reason for this is this. The examiners have been examining for hours, okay? They've been examining for days. They may be tired. They may not hear everything that you're saying when you're describing. They may be, they're human beings. They may lose concentration. But when you say, in summary, they will listen to that bit, okay? So it'll really help give you an opportunity to say all the bits that you really want them to hear. The important thing with Viva, getting ready for the Vivas is practicing, okay? And you've got to present yourself, you've got to practice presenting yourself as a safe radiologist. So knowing when to refer, knowing when to investigate further, that's safe. But it's also important to know when not to over-investigate. That's also a really important skill to have. A lot of people do fail the Vivas, okay? But some people pass overall because they do well in rapids and longs. And that's fine. But it's useful to know the reasons that people fail. A 4, and you have to get 24 out of 36 to pass, is where you miss the key findings, you make a wrong diagnosis or dangerous diagnosis, that's a 4. A 5 is where you're slow to spot the abnormality, you get poor differentials, and you needed some help to get to the diagnosis. Now, here, if you make a diagnosis that'll kill a patient in any of the Vivas, you could get a 4 in the whole Viva, okay? So they can say, we really need this doctor to sit the exam again because we're not confident that he's safe. And then they'll give you a 4 for the whole Viva. A pass is a 6, which is a bare pass, is where some of the abnormalities are seen with help. The principal diagnosis is correct. There's a limited differential. So this is where the examiner is sort of talking to you, trying to help you. And if you get the clues, you get a 6. If you don't, if you don't get the clues straight away, you probably will end up with a 5 or 5.5. A 7 is where all the findings are picked up very quickly. You make a correct diagnosis and you give a very good differential. And an 8 is a perfect response with absolutely no errors. Okay. Now, let's move on. Each modality counts. So here's where you get a case of, let's say, an X-ray followed by a CT. The X-ray is marked between 4 and 8, and so is the CT. So it's not the number of patients that you see, it's the number of modalities that you see that will. So if you see only 3 patients, but you see 5 modalities, then you'll be marked out of 5 modalities. The important thing here is to reset your mind after every marking event. So once you've had that X-ray, it didn't go well, and they show you a CT, reset your mind. You have an opportunity to show off now because they'll mark you out of 8 for that. Report every modality in enough detail, and that's important. And this is the score sheet we use, and it's almost identical to the one they use in the Royal College. Those of you who have had your sort of review done and have asked the college will be familiar with this. So they mark you for observations, interpretation, deduction, the use of clinical information, management, and safety. So you can see that safety is really important. And this is an example of how they mark it. And they will probably write some comments as well against that. So this particular person did 8 cases. There were 8 cases in the packet, but they only did 4. But they passed overall because even though they did badly in some of the cases, their overall mark was good. Now, examiners want a good pass or a bad fail. They hate uncertainty. They hate the case where they don't know whether you are safe or not. So getting a good pass is a good thing. And in some exams, like the Australian exams, it feels like to many candidates they're trying to fail you. But in the FRCR, certainly they're not. They're trying to get you through. They really do want more safe radiologists in the UK. They want people to have the qualification. They don't want your repeat fees. They rather get someone new to get the FRCR than continue getting your fees. So your goals for your vivas is to try and make the examiner's job as easy as possible by showing competence that you're a safe doctor. I'd say do not waste time on the hot seat. Try and see as many cases as possible to improve your average score. And the top mistakes I encourage you to avoid. This one is not just life-threatening, it's exam-threatening. You could, if you miss a life-threatening condition, you could fail the whole exam. Not having a script is another one. I really do recommend you get a script and get it in the next week. Start making your scripts in now, okay? And so I'd like to challenge all of you to get that script ready for the various body parts. And you could probably just, I mean, even if you put it onto ChatGPT or something and say, make me a script for an X-ray of the right hand, you'd be surprised. It might give you something that's quite useful, which you can modify. Staying silent about your reporting process is another mistake. And that means that, for example, you look at the case without opening your mouth. It creates uncomfortable silence. It's much better for you to express your thought process and get started as quick as possible. But not instantly. You know, you can give it a few seconds. 10 seconds is not uncomfortable while you're looking through the case. The other thing is not knowing anything related to the conditions that you are being presented with. So this is where your 2A knowledge becomes useful. And therefore, just a limited amount of knowledge around the conditions is useful. And I know that people use books like Crack the Core and other books like that for 2A. Just look through those cases. There are also a few books around long cases for the FRCR and Viva cases for the FRCR. You can just look through them to check, am I familiar? But please do not spend time learning theory. This is not a theory exam. It's a very practical exam, and the most you will learn is by doing cases over and over again. And the 5th mistake is not ending with management. Finish the case with management. I can't repeat that enough. And there are so many times when I do see vivas, do vivas, the candidate just describes the findings, give the diagnosis, and stops. The examiner is waiting there for you to continue, but you don't continue. And that's bad. You really need to look slick and continue to management. Now, boxers use visualization, shadow boxing. They prepare a bit for fights, and you need to do the same thing. You need to visualize yourself in front of your examination and use 15-minute sets to train your mind. There are some types of cases that you can get in vivas, and I'm just going to go through those. There are the absolute classics, where you've got a very obvious abnormality. Have a script ready for this. Have a script, you know, depending on if it's an adult or a child. If it's an adult patient, have a script, you know, have your surgical sieve ready so that you can go down it. That's an absolute classic. When you see that kind of case, say that, you know, there's a CT scan of the brain showing subarachnoid hemorrhage. It's as simple as that. It finishes it very quickly. There's also perhaps like this, where you've got an abnormality, but it may be in an atypical location. So this is kind of describing cases. And then there's the kind of case where you're trying to tie things together, where you've got sort of, biliary air, you've got, the gallstone, dilated small bowel, and then you call that gallstone ileus, or this one, which is arthropathies. Know your arthropathies. So know how to describe, erosive arthropathies. Is it asymmetrical? Is it symmetrical? Is there penicillin cup? Is there, boutonniere deformity, whatever? Know all your arthropathies, because those are common cases. And then there are rare cases where it's more about common presentations of rare cases. It's very unlikely that they will give you a rare presentation of a rare case. Now, so we use this technique of a staircase to success, or staircase to heaven. And in this case, if heaven is your FRCR for you right now, then the staircase to success is 1,500 steps. And that means being on the hot seat at least 1,500 times. So in order to help yourself to decide that, ask yourself, how many cases can you report in front of a mirror every week? How many cases can you report in a hospital every week? How many cases will you see in a monthly online Viva? How many cases can you report with a study partner or study group every week? And finally, when you go on courses, how many cases can you see? So write it all down and then see, does it come up to 1,500? So here is my question. Do you have a plan to see these many Viva cases? Because I'm going to present to you a plan, and I'm going to show you now how we can help you to get that plan together. It's not completely that we will completely solve the problem, but I'm going to explain a little bit about the courses, the subscriptions we run, which will probably help you to get that 1,500 cases in different ways. So if you can, yeah, excellent. That's exactly what we want to hear. So you have a plan. Anyone else? No? Okay. Does anyone else have a plan? So I'm going to presume that you do. So I'm just going to go through the courses, subscriptions, and a little bit about scholarships. So the most basic subscription we have to help people with the written exams is the written subscription, which has 80 curated written packets, which cover all the diagnoses that are there in the exam. And there are 30 long case packets, which covers most of the diagnoses that you'll get exam. And you can practice all these in an online platform. It's the only one really simulating the RCR exam. If you want only Viva practice, there is a Viva, monthly Viva subscription available. But the combined subscription is the one I recommend because it includes everything in the to be written. It has monthly online Vivas, which lasts about 12 hours every month on the first Saturday of every month, of which there are 6 sessions. Out of the 6, 4 sessions are what you need to attend. So there'll be at least 6 to 7 hours of Vivas on the first Saturday of every month. But the most important one, I think, is actually not number 3, which is the on-demand videos. We have lots and lots of FRCR teaching webinars to cover all the kind of the knowledge that you need for the exam. But knowledge is only so much. What you really need is practice. So study group sessions are the other one, and you need to practice that 3 to 4 times every week. Okay, we have study group sessions 3 to 4 times every week. And in every study group session, you'll see about 12 cases. Okay, so in a week, you'll see about 50 cases in the study groups. The ultimate subscription, which we unfortunately only have 5 spaces left, I think, for winter. This is for January. For summer, for the autumn one, it's completely full, so we can't we can't, there's nothing, there are no spaces on that. But if you're doing the exam in January, you get the FRCR 2B combined up to the January exam. You get Stat DX, you get 14 hot seats spread over 15 days of all the courses we run. There's the Norwich course, Cairo course, Southwest FRCR, Everlight, and Velour packets, and you get the additional 24 written packets, which are rapids and longs. Now, for those on the combined and 2B ultimate subscriptions, we are very, very, and you know, we are not for profit. And we are also aware that some candidates in some countries do struggle to afford it. So what we've created is a scholarship program where we give 50% of the 2B combined for 3 or 6 months and the FRCR 2B ultimate, whichever one you want to do. So it's 50% off. But and the benefits of that is that you can put, there are lots of benefits for getting a scholarship. You can put revised radiology on your CV, not education qualification, but you can put that as your experience. You can contribute to the revised radiologist educational resources to benefit the next batch of radiologists. So that's something that we expect. You gain teaching and presenting experience. You can polish your radiology skill, and you know, and you get obviously 50% off. So if I was someone who was doing the exam in January, what I would be doing is, you've attended this now, you'd get yourself the winter ultimate subscription at 50% off. There are things that you'll need to do. You'll need to contribute, but everything that you contribute is going to help you for the exam or help other candidates in the future. Okay, and there will also be an opportunity for you to participate as an examiner once you pass. So we are going to prioritize our scholarship candidates to become examiners later. You should attend the study group sessions 3 to 4 times every week. Attend our monthly vivas. Do 3 packets a day, 2 to 3 packets of rapid reporting a day. Do 1 long case packet a day, and you'll have enough to do. At least on a working day, you know, I'm talking about a 5-day week really. Watch the webinars for learning. Attend other things like Dr. Curtis has sessions every week. Dr. Khan has sessions that he runs. Please attend all those. They're all very good. Attend hot seats in the upcoming courses and do the written packets live during any of the courses that we do. And you'll be ready for the exam. That is basically the formula. So there you go. That is in a nutshell and pretty much comprehensively everything that is included. So can I have a little bit of feedback now from you guys? What is the one thing you have learned from this session that you're going to do? You know, is it something in the rapids? Is it something in the longs? Is it something in the vivas? What one action? What have you learned, and what action are you going to take? So I'm going to give you 2 or 3 minutes to think about that. Okay, I'm just going to go off camera and let you do that for a second. Yeah. Yeah, I really like this. Develop daily habits of organized studying. Excellent. Anyone else? Practice and discipline. That is absolutely the case. It's the key for success in all components. Absolutely. Anyone else? There are 15 people on this call. It would be really nice to hear some more. And if you want to apply for a scholarship, can I just say you can go to, let me just show you on the website where to go. So go to subscriptions, go to 2B, click on the combined, more info, and here there's a link on scholarships. It writes down a little bit of scholarships, and then click on here to apply for a 50% scholarship if you want it. But there are, as you can see, there are a number of things that you'll have to commit to, and we do only have limited scholarships, so you'll need to you know, apply for those. If you want a smaller scholarship, we have something called a mini scholarship where we give 10% off, which the only requirement for that is that you agree to be an examiner after you pass the exam. And obviously, we're not lawyers, we're not going to run after you or anything, but it's a sort of gentleman's agreement that if we give you a scholarship, a mini scholarship, then it's in your interest to give back to the next generation of candidates by doing a couple of sessions of vivas where we give you the cases, and so it's actually quite easy and it's great practice. And if you're a UK registrar, it can go towards your ARCPs. It's a teaching experience, so that's very useful. And if you're not a UK registrar, then it can go towards CSER later in life. Okay. So is it only 2 people who can answer that? If you're uncomfortable with Slido, then please can you fill it in the chat, because I'd really like to know that what we've said has been useful for you. So I'm going to stop the presentation now.